What's going on, y'all? It's your boy Mike here with another video. I know a lot later than I usually would post. It was just a really busy week for me last week. But I just want to talk to you guys about what it's like to work in ICU as a physical therapy assistant. Um, it can be nerve wracking at times because it's a different world. Working in a hospital is just different. But working, depending on which floor you work on, people are a little more intense, a little more sick. Um, Working in the ICU, first thing I say, stay calm. Stay calm, stay calm, stay calm. If you're curious about something, ask. Um, there's a lot of lines, a lot of beeps. People are very, critical. Um, Depending on what type of ICU you're working in, depending on even the patient, there are certain things that you can do, you can't do. Um, on a traditional floor, patients, their conditions can change fairly rapidly. In the ICU, it can change very rapidly. For instance, there's this patient that I had a couple weeks ago, and it was in the morning. It was like 10 o'clock or something. I was like, hey, I was just running with the nurse. I was like, hey, can I see this patient? And if you're like, yeah, go and see this patient, so on and so forth. All right, okay, cool. After see this patient, I'll come right back. Went to see one patient, went right back. Like, nope, can't see him. What happened? Vital signs just started tanking. I'm like, okay then. Another patient, I had them the day before. Working with them, working with them. Their oxygen started. Like, whenever they stood up, the oxygen started to fall. Now, with oxygen, the best way to describe it to people is you want it to be like your grades in I won't say grade school. I'll say more like in college, because depending on which college you go to, they'll consider 92 to 100 an A, like 83 to 91 a B, so on and so forth. And I tell my patients, I'm like, hey, we're A plus students. We want to have our grades as close to an A. So also A plus. A's A's are still good. A minuses is like, okay, not too bad. When we get to the B plus range, we're like, what's going on with this? Numbers wise, so again, 95, 96, 97, 99, 100. Sweet. 94, 93, like 94, 95, 93, 92. It's like, okay. 92 was like, okay, a little bit on the lower end. 90 was like, 90, like 89, 88 is like, what's going on? Things like that. Working on the patient, before we moved, patient's oxygen was running mid 90s. Not bad at all. Stood up watching him, going down to like 85. Like, huh. So before I begin, I see, don't panic. Observe, see what's going on. Look at him like, how do you feel? I feel okay. Look at their grip, because again, they're usually wearing a pulse ox, so little. So, and depending on which unit that you're working on, depending on the hospital that you're working on, let's take a little piece of tape that's strapped around their finger that reads their oxygen. Looking at that, it's like, okay, how are they gripping the walker? Because depending on how much you grip, you can reduce your circulation a little bit, affect readings, things like that. So looking at the grip, looking at the patient, looking at what we call the pleth, like pretty much the wave pattern, looking at that, looking at the number. So, okay, cool. You feeling good? I'm feeling good. Dizzy or anything like that? Nope. Okay. Still doing our thing, watching it. Number starts dipping down a little more. So mid 80s, low 80s. Okay. Go ahead and sit down. Recover. Sit down. Let go. Oxygen. No. Oxygen starts coming back up. How do you feel? I feel good. Okay, go. Sit, relax, rest, so on and so forth. Things like this happen very often. Sometimes they'll have an A line, so it's literally a line that goes straight into like their artery, and it's like checking their blood pressure. Like it's very accurate. It's way more accurate than a blood pressure cuff. Way more accurate than a blood pressure cuff. So sometimes you have A lines, which are very positional. Again, depending on where the person's arm is, depending on where they have the monitor for the A line, it can actually make a big difference on how things are reading. So they have A lines, so you have to move depending on what's going on with that. Depending on what's going on with the patient, they'll have like a BiPAP, all these different things. So there's a lot of lines that go on in ICU. It can be overwhelming, but patients can do a lot more than you think they can do. You can do a lot more with patients than you think you can do. If you are concerned, confused, I always say ask. Ask for assistance, ask for help, ask the nurse. Again, before you go into a patient's room, after you leave a patient's room, you talk to a nurse, make sure it's okay to see the patient. Because again, just like I said, the first patient I had, if I just went off with what they said at 8 o'clock or 9 o'clock, I would have gone to that patient's room and work with them, da 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 da. But then I went back and asked, like, hey, is the patient still okay? And they said, no, because of this, this, and this. I'm like, okay, cool. That's why you always talk to your nurses, because things can change very, very fast. Always talk to your nurses before you treat a patient. In ICU, there are certain things that you can connect, you can disconnect, but also it's nurse dependent, because some nurses are very, very particular with their lines for obvious reasons. So make sure that it's okay with the nurse first. And if you're not 100% certain that it's okay with the nurse, just ask the nurse to come in and say, hey, do you mind connecting this or disconnecting this so we can do this for therapy? Or they'll say, yes, we can do that. No, we can't do that. And again, depending on what the nurse says, depends on what you can do. Sometimes we're able to walk around the units. They're able to be freed up from certain things. Sometimes you're just standing and marching if they're not allowed to be freed up from different things. Sometimes, with ICU, again, patients are very, very critical. So sometimes we're very, very limited. Sometimes we're just doing exercises in bed. It's like, hey, move your arms, move your legs, so you don't get too stiff, so you don't get any contractures or anything like that, or so you don't run the risk of getting contractures. Sometimes we're just working on bed mobility, because again, if you're moving, sometimes blood pressure can do all sorts of things. So sometimes oxygen can do different things. So you have to be extremely careful working ICU. But it's fun. You get to learn a lot. You get to see a lot. You get a lot more respect for medicine as a whole. Like, being in medicine, you have a certain respect for it. But whenever you walk into an ICU room, so let's say you walk into I don't say a baseline ICU, but a ICU where a patient is not extremely, extremely critical, but they're more critical than PCU. They may have 3-4 pumps, things like that. A line, all things like that. It's like, okay, cool. You can do this. It doesn't. It's still awe-inspiring, but it's like, okay, cool. However, sometimes you walk into an ICU room, and you'll literally see a trach, an A line, 6, 7, 8 blood pressure medicines on the patient. Their medicine and medically induced coma, all these different things. One time I walked into this patient's room that they had something going with their neck. So their neck was, again, this may be too TMI. If it is, close your ears for a second. Exposed. It was covered up, but it was exposed. Walked into a patient's room one time. Stomach surgery. Because the patient was so critical, and they had to go in so often to get things cleaned up. It was covered, but open. I've seen people as feet. Again, I work with a lot of vascular patients. So you're working with vascular, and then amputations. They still have a bunch of IVs going with that. There's so many different lines that it's like it gets a lot. That's why I call it spaghetti, because that's the best way to describe what you see sometimes in some rooms. It legit looks like spaghetti. It's like, what do you do with all these lines? How do you manage all these lines? How do you understand all these lines? And that's why you get that deeper level of respect, for your nurses, for your RTs, for your doctors. Doctors already have a certain level of respect, but you have that much more respect whenever you hear them talking. They're going, oh, da da da, and they're just rambling things on, just like it's another day. But they know exactly what everything means. It's like, holy crap. And then the nurses, it's like they know exactly what a doctor means, and they're running the ship. And they're like, okay, patient does this. Okay, nurse is doing this, and this. Like, holy crap. And then you walk in, you're like, hey, can I walk this patient? And they're like, sure. And they have 6 IVs running. It's like, what in the world? So it gets it gets intense. It gets very, very intense. Um, and that's why, typically speaking, before you work in ICU, before you go into ICU alone, you have therapists who works in ICU a little more frequently. You have them going into ICU with you, so you have someone to someone to have your back, someone you can bounce things off of, and someone who just has a little more experience than you in that particular setting. That's one of the things about there. There's certain things that you can do. Again, always read the doctor's notes, particularly before you work with a patient in ICU. I say read the therapist's notes. If there's something that's like kind of interesting, like there's like a surgery note, try to pick up the surgery note because again, things can change very, very frequently. But it's not as bad as you think it would be. It can be very, very intense, but trust yourself. Trust the medical team that you're working with. Trust your nurses. Trust your RTs. Because again, without them, you won't be able to do your job. And sometimes you're doing therapy and they're legit checking the monitors. They're legit like, okay, what's the patient's heart rate? What's the patient's oxygen? Are they on BiPAP? What's so on and so forth. They're doing everything. Like there are patients that they're on a balloon pump, and when we have to walk them, it takes a minimum of 3 people to walk this patient. It takes the therapist. Well, I'll say a minimum of 2 people, the nurse and the RT. But generally, whenever we're working with them, it's a minimum of 3 people. So the therapist who's watching the patient, who's checking, their stride, their energy, their gait quality, things of that nature. You have the RT who's actually running checking the balloon pump, monitoring that, make sure that everything is going perfectly fine. Then you have the nurse who's like checking the IVs, checking the blood pressure, all these things. Also, in particular ICUs, you have to walk with a nurse. Because again, depending on what's going on with the patient, patients are extremely critical. Obviously in ICU they're gonna be critical, but there is like a severity, if you will, of criticalness. But again, for these patients, you're walking with 3 people. You may have fresh open heart surgeries that you're working with, different things like that. So, man, just want to chop up with you guys a little bit. Talk about what it's like working in ICU. It can be intimidating. Trust yourself. If you're like, hey, I'm a little nervous about this, ask your nurse to help you out, because we're a healthcare team. We're not individuals. We're working as a team. Trust your team. Trust your nurses. Trust your RTs. Trust yourself. And if you don't trust yourself, if you're worried about this, ask your supervisor, your manager, whoever is above you therapy wise, to say, hey, I'm about to go into this unit, but I am nervous. Do you mind helping me out? Because I'm pretty sure, I can guarantee that your supervisor would prefer you to ask for help in ICU instead of you just trying to wing things in ICU. I'm pretty sure about that. So, if you don't trust yourself, ask your supervisor for support. Ask them to shadow people in ICU just so you can get that level of comfort and familiarity, so you can do things you gotta do. But yeah, just want to chop up a little bit. So we talked about amputations previously. We've talked about stone precautions. This one's about ICU. If you want, we can talk about some hip and knee precautions. We can talk about some things that unorthodox. I mean, talk about some unorthodox things that we can do in a hospital as therapists. That'd be a pretty interesting one. Just get you thinking outside the bubble a little bit. I think that may be next. We'll see what happens. But that's what I got for you guys. Until next time. Later.